Good afternoon, everyone, and welcome to our 8th lecture of the year for the Emeritus Academy. And hello to everyone up there online also. For people that aren't in Columbus, let me say it's, according to my watch, 82 degrees. Beautiful spring day, summer already. I don't know what we're in for this summer. But let me start by doing a few things before we introduce new members and then get into our lecture. First thing I wanted to say was that TK Daniel cannot be here because on Monday, he was asked to be the commencement speaker for the College of Education and Human Ecology. So right now he's taking the stage in Meerschaum. But I wanted to thank TK, who is stepping down, retiring as past chair from the steering committee after 4 years. But along with TK, we lose BB Miller and Julia Watson after their 3 years of serving on the committee. And I want to thank them for their many ideas and continuous support of the committee and the Emeritus Academy in general. I also have the pleasure to announce that Michael Griever from Medicine Hematology will be chair-elect this coming year. And he was going to be here this afternoon along with Mark and I, but he has clinic. And he's trying to come, but I don't think he's going to be able to make it. Yes, next. And Mark DeBeard will be moving to the committee chairmanship this summer as I move along to become past chair for next year. And typically, if you've been here in the past, when we introduce new members, our very important vice provost, Helen Malone, is usually with us to welcome the new members, but she's been called into some administrative things for today also and cannot be here. So I'm going to ask Mark to come up with me and we are going to sort of tag team while he's going to speak all the members' names. And between Jackie and I, we will be handing out the certificates to those of you that are here. After your name's called, please come up. After we go through that, folks who might be online that are new members. Mark, take over.
All right. Well, this is always sort of a fun time of year. We do it a couple times a year. And we have 20 new members for the Emeritus Academy this spring. There are obviously a fair number of them who cannot be here today. I'd like to at least announce their names and what departments they're from so everyone can be aware of them and we can acknowledge them. The ones that I know are not here and said they couldn't be are KB Jones from Architecture in the College of Engineering, Barbara Hager from the History of Art in the Department of Arts and Sciences, and Louis Clayman from Periodontology and Dentistry. Those three I know can't be here. The others I don't think are here that I'm going to mention. If they are, would you please stand, raise your hand or something, and we do have your certificate here with us if you happen to be here. Jareen Balduff, Clinical Nursing, College of Nursing. Lee Gilmore, Department of English, College of Arts and Sciences. David Greenberg, Pediatrics, College of Medicine. Tamar Rudavsky, Department of Philosophy, College of Arts and Sciences. Alan Silverman, Department of Philosophy, College of Arts and Sciences. Amanda Simcox, Department of Molecular Genetics, College of Arts and Sciences. David Stein, Department of Educational Studies, College of Education and Human Ecology. And Ed Valentine from the Department of Art in the College of Arts and Sciences. If we could give them a hand. The ones who I think are here today, as I call your name, please come up and receive your certificate from our chair of the steering committee, Ardeen Nelson. The first is Marty Golubitsky. Marty is from the Department of Mathematics, College of Arts and Sciences. I see he works in symmetry and patterns in physical systems, network architecture with biological implications, which I saw had to do with gait, vision, and homeostasis, which sort of interested me since I'm in medicine. I didn't realize math had that many applications to it. Later, yeah. Thank you very much. The second new member is Barbara Kiefitz. Barbara is from the Department of Mathematics, also College of Arts and Sciences. Is a expert in partial differential equations, and I believe originally from Canada. Is that right?
Absolutely.
Right, Canadian American. My sister was born in Gaspé, Quebec. So she got 2 passports too. Yeah, that's a good way to do it.
They both run out at the same.
Yeah, they do, don't they? More money, right? All right. Third is Lawrence Madden, Department of Plant Pathology, College of Food, Agriculture, and Environmental Sciences. He works on math and plant diseases and crop epidemics. As a very amateur lilac horticulturist, I found some of your work really interesting, so thank you. Next, Peter Shields. Dr. Shields is from the Department of Internal Medicine in the College of Medicine. He works in oncology research, and I think specifically on lung cancer research, if I remember reading right. Yeah, thank you very much. Next, Dr. Patrick Vaccaro. Vaccaro, who I have heard of at a distance. I worked at University Hospital East, so I didn't get to meet you or know you very often. Vascular diseases and surgery. He was chair of the department, if I remember right, College of Medicine. Well, congratulations, and thanks for being here with us. And Emily Regnier, I'm going to assume it's pronounced that way, but if I were French, I would say Regnier. You like the Regnier? Oh, good for you. Although the French would spell your first name Amélie with an A. They still do the E? I-E at the end. Yes, I knew that part. So Emily Regnier. So Emily is from Department of Horticulture and Crop Sciences, College of Food, Agriculture and Environmental Sciences, and a weed specialist. And why are you interested in ragweed? I never figured that out. So, oh my God, and giant ragweed too. I was out there today, I don't know. But thank you very much for doing what you do. We have a few that we think might be attending on Zoom. So we're going to look up at the monitor and see if you're here as I call your name. Please wave to us. The first would be Dr. Mark Angelos. Are you up there, Dr. Angelos? Don't see Dr. Angelos. Oh, there he is. So Dr. Angelos is a former chair of the Department of Emergency Medicine at Ohio State. He was a fabulous researcher, a leading emergency medicine researcher in the country, and I am proud to say, a former resident of mine many, many years ago in emergency medicine down at Wright State. So Mark, congratulations. The second is Karen Mansell from Department of Food, Agriculture, and Biological Engineering, who researches wastewater treatment and environmental issues. Karen, congratulations. Good to have you here. And the last one that I have is Sally Miller. Are you up here, Sally? Don't you see her? Carol Miller, is that the same person? Well, at any rate, Sally is from the Department of Plant Pathology also, and she researches vegetable crop management diseases. She's especially interested in integrated pest management, which is a fancy way of saying handling insects and diseases in a stepwise fashion and not going to chemicals right away, which is one of the things I've learned lately. And she has a particular interest in Phytophthora, which I had to learn about because it keeps killing some of my lilacs about one a year. It gets down in the roots of them and the whole plant just dies suddenly for no good reason, which happened to a crabapple of mine this year as well. So Phytophthora is actually more important than many of us think. And that's our complete list. Thank you very much.
Okay, on with our reason, a real reason for being here, the lecture. And Dr., I'm going to screw it up, I'm very sorry. Wickizer joined the faculty at Ohio State College of Public Health in 2009. He's the first Stephen F. Loeb's Distinguished Professor of Health Science Services Management and Policy. He has served as chair of the Division of Health Services Management and Policy in the College of Public Health from 2012 until his retirement in 2020. Prior to joining the faculty, he served for 20 years on the faculty of the University of Washington School of Public Health. He was awarded the Rome Haas Distinguished Professorship of Public Health Sciences in 1997. He's published widely in leading public health journals as well as health policy and clinical journals. His area of studies include community-based disease prevention programs, occupational health interventions, healthcare cost containment programs, substance abuse treatment outcomes, prescription opioid use, and more recently, gun violence and firearm suicide. His current work includes research on the fentanyl epidemic, support in part by funding from the U.S. Department of Justice Drug Enforcement Administration. This research examines years of life lost due to fentanyl and associated economic costs. Surveys harm reduction centers and their operation and organization, and proposes a strengthening strategy to strengthen the ability of communities to combat the fentanyl epidemic, which leads us into today's lecture, the American Fentanyl Epidemic. Welcome.
Thanks for that kind introduction. Let me just take a second here and put my slides on my laptop if I can. Okay. Well, thanks for coming. It's always nice to come back to Columbus. I now live in Seattle, but we still have quite a few friends in German Village where we used to live. So it's a combination of socializing and coming to give the lecture. I don't have very good news today on the topic. And people, I think, who are studying the fentanyl epidemic, the general prevailing view is it's likely to get worse before it gets better. So, but I want to just acquaint you really with some of the background and the facts about the fentanyl epidemic. I think there's a lot of misunderstanding about it in some ways, and present some data that we're hoping here in the next little bit of time to publish. There's a lot of different ways to view the impact of an epidemic like fentanyl. We're taking more of a narrow economic view of it, just because that's what we decided to do. So I want to just acknowledge a couple of people. Rachel Mason, raise your hand. Rachel's a PhD student in public health, and she does a great job helping me out in a variety of ways and rescuing me from time to time. Evan Goldstein is now an assistant professor at the University of Utah. He used to be a PhD student in public health, and he was responsible for generating the data that I'm going to report on. And I'd like to also acknowledge support that I received from the Emeritus Academy to do some of the work that I'm going to be talking about today. So I'm going to share with you some data on death rates, years of life lost, economic costs. I'm going to start by comparing the fentanyl epidemic with the smallpox epidemic and its eradication. And then I'm going to present some data on harm reduction from a survey that we did that was supported by the DEA. Talk a little bit about the site up at Cleveland, which actually was far and away the best site that we surveyed. So I'm hoping perhaps to make a site visit there and write it up, because they're really doing some important work. And then I'm going to close by talking a little bit about prevention approaches and sort of where do we go from here. I'm not an expert in prevention science, so I'm going to be talking more from about a 5,000-foot level. So to begin with, smallpox. Many of you, I think, know it's one of the deadliest diseases known to humans. It killed as many as 1 in 3 people, millions of people dating back really thousands of years, actually, to ancient Egypt. In 1967, the World Health Organization initiated a worldwide campaign to actually eradicate smallpox, and it was declared globally eradicated in 1980, the first and the only infectious disease affecting the human population to be completely eradicated. I was, after college, went in the Peace Corps in West Africa, in Ghana, and was fortunate enough to get a special assignment at a United Nations site working on the smallpox eradication program. So our job was I directed a small medical field unit team on Lake Volta, which is located in Ghana. And we vaccinated the fishing villages against smallpox. Children got measles, yellow fever, and depending on where we were on the lake, cholera. So this is a map of Ghana. Actually, Lake Volta is the largest, by surface area, the largest lake in the world. It was created when the Akasambo Dam was built back in the 60s to generate electricity for a very large aluminum smelter that was located on the coast. In the late 60s, the CDC teamed up with WHO and sent teams of infectious disease physicians, epidemiologists, logistical support personnel to 20 West African and Central African countries. And we were able to, in the span of about 18 months, vaccinate about 35% of the fishing villages on the southern part of the lake. We never got way up there. But there were a lot of challenges. Among them were just logistical challenges, transportation, vaccine storage, coordination and language barriers. And as I was putting together and thinking about my talk, I thought, in some ways, I think as unlikely as it may seem, that containing the fentanyl epidemic will prove to be more difficult than eradicating smallpox. So this is a quote from 2 people from 2019. Quote is, sadly, but perhaps predictably, beginning in the late 1990s, America has witnessed an increase in drug overdose deaths in numbers partaking of biblical proportions, due principally to the overuse and misuse of opioids, legal and illegal. A little bit about the history of fentanyl. Fentanyl does have widespread use, therapeutic use. It is a potent synthetic opioid. It was first synthesized back in 1960. It was introduced to the US in 68 as an intravenous analgesic. 1980s, it became widely used for patients having cardiac and vascular surgery. It came off patent in 1980 and sales increased immediately, substantially tenfold. And fentanyl is now the opioid most widely used intravenously for intraoperative analgesia. So it certainly does have important medical use. On the other hand, the illicit fentanyl first made its appearance around about the late 70s. It was then known as China White. It's become the principal cause of America's drug overdoses and fatalities. Around 2013, large amounts of fentanyl began to be shipped from the U.S., shipped to the U.S. from China. In 2019, the supply sort of pivoted to Mexico, which became the principal site for illicit production of fentanyl by the drug cartels. So a lot of the precursor chemicals are sent now from China to Mexico. They're synthesized in illegal labs in Mexico and shipped up to the United States and Canada. Why is fentanyl the new scourge? It's probably, as many of you know, it's extremely potent, 50 to 100 times more powerful than morphine. Some fentanyl analogs, carfentanil, are up to 1,000 times more powerful than morphine, and a few grains often prove fatal to humans. One of the reasons why Ohio has a fairly high death rate is for some reason that is not completely understood. The use of fentanyl analogs is higher in Ohio than other states, and they tend to be more potent and lead to greater risk of death. Fentanyl can kill instantly because of its potency. There's little difference between the maximum therapeutic dose for analgesic effect and the minimum fatal dose. It's easy and cheap to produce, smuggle, and distribute. Roughly a $5,000 purchase of the chemical precursors can yield as much as $1.5 million, and it's much cheaper to produce than heroin. It costs a fraction. And so a combination of, in the old days, I say the old days, prior to probably about 2005, it was more difficult to synthesize. And so you really needed advanced training in chemistry. But that began to change, and different and easier ways to synthesize it were developed that you can't exactly create it in your kitchen, but it's much easier to and cheaper to create now than it was 25 years ago. So something about the impact of fentanyl. I will apologize in advance. The tables that I'm going to show are pretty detailed, so I don't know if all of you can see them, but I'll summarize them. So this slide shows sort of three waves to the opioid epidemic. And the first wave is the blue line, which is commonly prescribed opioids. Oxycodone, everybody's heard of that story. And then starting in about 2010, 2011, there was an uptick in heroin that's shown in the orange there. The commonly prescribed opioids, I'm sorry, this is deaths per 100,000 population. So we're talking about death rates here. But if you look at, starting at about 2013, the upswing in deaths due to synthetic opioids, which for all intents and purposes are fentanyl. That's really been the driving force for the increase in all opioid death rates since about 2013. This slide shows the increase for males and females in death rates up through 2021. And you can see how the dotted line is female death rate. The male is the black line, and the combination is the gray line. But starting in about, I don't know, 2015 or till maybe 2016, the death rates really did increase, and in fact increased 275% between 2016 and 2021. So it's really the last, what, 8 years or so. We don't have the most recent fully validated mortality data, as far as I know, is 2021. 2022 should be coming out soon, but it's just provisional. So this slide shows for the US overall for 2021, the death rates by age. And you can see I've highlighted in red that really males and females aged 25 to 44 make up the majority of the years of life lost and the estimated economic loss. That these figures are in present values, because if somebody dies at 25, then society loses their productivity for 50 years or so. And so you can, calculate that and factor in labor force participation rates, and, the expected work retirement ages. And you can see that the death rates per 100,000 for males, 56.5 for males aged 25 to 34, 60, almost 61 per 100,000 for males aged 35 to 44, quite a bit less for females, approximately 21 per 100,000 for females 25 to 34, and about the same, a little bit higher, almost 23 per 100,000 for females 35 to 44. The total years of life lost in 2021 were 2,521,816 at an estimated cost of just under 48 billion. But that's for reasons that I won't bother to go into as a conservative estimate. $47 billion. Almost 48 billion. This slide, there's a lot of variation in fentanyl death rates, and the use of fentanyl. The East Coast is more, and Appalachia, including Ohio, is more saturated relative to the Midwest, and certainly relative to the West Coast. So these are the 6, 7 states with the highest and the lowest age-adjusted mortality rate. And you can see West Virginia, who's been in the news a fair amount, is the state with the highest rate, 72 per 100,000. District of Columbia, Delaware, Tennessee, Kentucky, Maine, and Ohio's death rate in 2021 was 37 per 100,000. States with the lowest age-adjusted rates are shown at the bottom of the slide, and they're substantially lower. Hawaii, 3.6, South Dakota, Nebraska, Utah, Texas, Iowa, they're all in the range of about 3.5 to a little under 7. So there's quite a spread and geographic diversity in the mortality rates. And this shows the death rates for the highest counties and the lowest counties in Ohio. Franklin County, you'll see, is highlighted in red. It's 52, almost 53 deaths per 100,000 people. but the death rates are substantially higher for Lawrence County, Scioto, Honing, Ross, and the counties with the lower death rates, lowest death rates, are shown at the bottom of the slide. And those rates range from about 11 to 23. So within Ohio, there's a lot of, there's quite a diversity in death rates. So just to summarize, illicit fentanyl accounts for a great loss of life among young and middle-aged persons. It's now, in fact, the #1 cause of death for people 18 to 45 in the country. The annual economic loss conservatively is on the order of 48 billion, resulting from 2.5 million years of future life lost annually. But the economic cost really doesn't begin to account for the intangible costs to families and friends, communities, and really to the nation overall. And so we really must find approaches to do a better job in reducing the death rate and the loss of life. So some information about current approaches to the epidemic. What they really emphasize, broadly speaking, law enforcement and harm reduction and treatment. I probably should have included treatment on here. Law enforcement efforts at the federal level is really the responsibility of the Drug Enforcement Administration, or DEA. It enforces the laws regarding controlled substances and regulation. It really aims to reduce the supply of and the demand for such substances. In 2022, the DEA seized over 50 million fentanyl-laced fake prescription pills and more than 10,000 pounds of fentanyl powder, which is just, imagine those quantities. It seized enough fentanyl to kill at least every American. 60% of the seized pills contain potentially lethal dose of fentanyl. And so, harm reduction really focuses more on the demand side, and it's been, European countries and Canada have used harm reduction more widely and earlier than the United States. It really is an effort to improve the safety and decrease the risk of using different substances, not only opioids, but other substances. And it really encompasses a range of services intended, as I say, to reduce harm and health risks of substance use. There's only about 1 in 10 persons with a substance use disorder receives treatment. Most feel that they don't need treatment. The harm reduction services include prevention and counseling, distribution of fentanyl test strips, HIV and Hep testing, provision of health services, referral to treatment, and outreach. So it's really a range of services that are offered. Part of when I was working with the support of the DEA, they were interested. I worked with some lab scientists back in, I think, Silver Spring, Maryland. They have a very big DEA lab there. And they were interested in doing testing on fentanyl test strips to see how reliable the results were, not in a lab setting, because fentanyl test strips, if they're going to be used, they're going to be used by adults or young adults in Columbus in the winter as well as the summer. They may remain in your pocket for a couple of weeks. And so they did some interesting work and published it in the in forensic chemistry, I think it was. And it basically showed that fentanyl test strips, there are false positives and false negatives, but overall they're quite reliable. The limitation is the current generation of fentanyl test strips only results in a binary kind of outcome. Either your product that you test either has fentanyl, contains some level of fentanyl, or doesn't, but it doesn't tell you anything about the potency. So fentanyl test strips, and actually Ohio changed its law in April of 23, maybe April of 22. But up until that point, fentanyl test strips were considered drug paraphernalia. So actually people who were caught with them, or organizations who were distributed in them, in theory, could be subject to criminal sanction. Many states have changed that now. And there's wider use of fentanyl test strips. And fentanyl test strips really aren't a magic bullet at all, but I think the tragedy of the two undergrad women at OSU who died, I think in May of 22, it was May of 22. They wanted to get through finals week and write their papers and study for exams, and they bought, I don't know if they bought online or they bought it from a friend of a friend, but just what they thought was Adderall, not contaminated, and they both ended up in the Wexner Medical Center a few days later, dead from fentanyl that had contaminated the Adderall. So had they had fentanyl test strips, they might be alive today. OSU now provides them at the Student Health Center. I think that's also somewhat new. I think earlier they provided them in the Student Wellness Center and some office in the RPAC, but now they are dispensing them at the Student Health Center.
Oh.
So we undertook a web-based survey of harm reduction programs to assess their organization and operations and what services they provided. We surveyed 72 sites. It was a convenient sample and included some sites that the DEA wanted us to include, presumably because, I don't know, if they had seized fentanyl in those areas. But we surveyed 72 sites, really, from Miami to Seattle and Boston to LA. They range from New York City to Pine Bluff, Arkansas, population of 40,000. And the survey involved online queries to collect just descriptive information on hours of operation, program organization, services available. So just some data here for the next couple slides on the organization and operations. So basically 80%, 79% of the 72 sites surveyed had some form of harm reduction program or participated in the state or regional harm reduction collective or collaborative. The formal organization varied among the 57 programs that did have, the 57 operating programs. 30% were part of a regional program and had no local formal organization. 14% had a board of directors, but no mission or goal statement. 33% were more highly organized in that they had a board of directors and a mission statement. And 23 were part of a local health department or government agency. The organizational structure varied somewhat. 59% were freestanding community-based organizations. 13% were part of a local or state health department. 9% were part of a local government. 7% part of a large healthcare organization, and 12% other state collaborative or religious. Staffing and hours varied. Almost all of the community-based programs were staffed by volunteers, and the hours of operation varied, but were really quite restrictive. 28% were open Monday to Friday, with fairly small percentage of those programs having some weekend hours. 28% had more restricted hours that were open fewer than 5 days per week. 16% had highly restricted hours. Maybe they were open a few hours in the morning and a few hours in the afternoon, a couple of days a week. 8% were by appointment only. 9% were part of collective online remote services only, and 11% didn't have any hours listed on the website. So this slide just presents a little bit of data on the services. About 70% of the programs distributed naloxone. 74% offered some sort of syringe service. 86% other services included HIV and hep testing, referral, and counseling. But only 44%, less than half, distributed fentanyl test strips. So the kind of mosaic here, I think, is a harm reduction programs that operate on a very limited budget, are staffed by volunteers, and basically, with the exception of Cleveland, and there might be a couple of other sites, really weren't very well integrated in the sense that they weren't integrated with local public health or with state public health or with local law enforcement or with the local medical community or with the local education community. In contrast, Cleveland, which is a program sponsored by Cuyahoga County, was well integrated. It gets routine data from the DEA regional office in Youngstown. It gets data from the local medical examiner's office. It does active outreach to schools. It's been successful in obtaining grant funding for new programs. It uses, seemed to me when I interviewed a couple of people up there on the phone, in addition to doing the online survey, that they really did use data in making many of their decisions. And it seemed to us that they had quite effective management leadership. So it really was a program that stood out. And probably one of the reasons is it was part of Cuyahoga County. And so what they told me is, well, when they started passing out fentanyl test strips, the local police gave them a pass because probably they were part of Cuyahoga County and, you know, had that formal relationship. So some thoughts about the present approach to combating the epidemic. Really, the present approach relies on harm reduction to reduce risk and promote safety. It relies on law enforcement to reduce supply of fentanyl. It relies on increasing availability of naloxone and fentanyl test strips. Those are important developments, to be sure. And a variety of community prevention activities, as well as treatment. But the approach really lacks coordination and integration of programs and services. It's by and large not data-driven. There's a real critical need for epidemiologic data to better understand subpopulations that are at risk for overdose from fentanyl. And it lacks a social marketing campaign to improve public awareness. So there are some important things being done, but in relation to the magnitude of the problem, where we're talking about the #1 cause of death of people in young adults and middle-aged adults, it's really not enough. So combating the epidemic, some thoughts on the future. The approach, I think, and I'm not alone in this by any means, really needs to rely on public health science, prevention science, medical and clinical science, and then public policy based on data generated from these sciences. Now, I just don't see much evidence of that. so far. Not to say that there's not people that are in the field of prevention science not doing good work, but I think there's no overall coordinated, integrated approach at either the federal level or for most states. The future approach will require, I think, among the things that will require really is improved coordination, leadership and program integration across public and private sectors, social media campaigns to improve public awareness, data-driven strategies based on applied science, and recognition really of the diversity in the fentanyl user population. One size won't fit all. I mean, the problem of inner city Philadelphia and inner city Baltimore is vastly different than the problem in rural Kentucky and rural Ohio and rural West Virginia. And I think that's just gotta be recognized. Earlier in my career, when I was at the University of Washington, I was involved in this big community trial that the Kaiser Family Foundation had funded when Al Tarloff was directing the foundation. And it took place in 11 Western states. And it was really designed to help communities develop interventions to improve community health. In those days, there'd been quite a bit of work in cardiovascular risk reduction demonstrations, both in the United States and in Europe. And the idea that we came up with in trying to wrap our arms around how are we going to evaluate this demonstration was kind of anchored in this concept that we called activation. The idea was to activate communities to promote health by improving organizational coordination leadership, improving public awareness about health risk, whether that was adolescent pregnancy, substance abuse, tobacco use, and institutionalizing the programs to promote long-term viability. So it wasn't just that the Kaiser Family Foundation parachuted in with some money for 3 or 4 years and then left, and then the programs, were not institutionalized, and so were at risk for not being able to continue. So I think that there are some lessons from this earlier work that people did. And there were people at the College of Public Health at Ohio State that were integrally involved in a big Minnesota heart study that took place at the University of Minnesota around about this same time. And so I think we could borrow from some of that experience and in a judicious way apply it to the fentanyl epidemic. So a couple of concluding thoughts on these last 2 slides. Fentanyl, as I mentioned, has become the #1 cause of death in the U.S. for persons 18 to 45. This goes without saying. We really can't tolerate the loss of life and economic costs associated with this man-made epidemic. Containing the epidemic will require, again, these are fairly obvious, sustained commitment, new and more effective coordinated strategies, increased resources, and also reducing stigma that often accompanies substance use. So smallpox and COVID-19 were contagious disease epidemics, and we developed vaccines and took preventive measures that eradicated or contained these diseases. But fentanyl is really man-made and multi-layered. It includes social factors, economic factors, environmental factors that pose risk for different population groups in terms of using fentanyl and being at risk for dying from fentanyl OD. And success in containing the epidemic will depend, among other things, I think, on our ability to address some of these underlying factors, which will not be easy, but I think will be necessary. So with that, I'll take questions. No, they really don't have anywhere near the fentanyl problem that we have. Estonia, which is a former country in the Soviet, Soviet Union, used to be part of the Soviet Union. Now it's an independent country. They, in the past, were the country. It's a small country, but with the highest death rates. But in Sweden, to a limited extent, some other countries, but their death rates are a fraction of ours. I think the overall death rate in Sweden is about 9 per 100,000. And they tend to, in terms of illicit opioids, tend to rely much more on heroin that comes from Afghanistan and that region. Yeah.
We have microphones.
Are there any specific profiles of the individuals who are most vulnerable? Number one, and number two, what kind of barriers are there to get these individuals to really accept the message?
Well, that's a good question. I think that there are subpopulations that have different profiles of risk. I mean, you have people who are street users who are fairly savvy, they know their dealers, and they have some opioid dependence, and they may actually prefer the high of fentanyl in addition to, say, heroin. And so you have that group that's fairly knowledgeable in terms of street use, but they're also at risk because they use a lot of drugs. And if they get some drugs from a dealer that they don't know or they don't trust, those drugs may be highly contaminated with fentanyl. And then you have, for example, the situation where young people are going to a concert and they're not street drug users, but somebody scores some kind of drug that they think will give them a better time at the concert, and it happens to be contaminated with fentanyl. Clearly, for those kind of people, if they had ready access to fentanyl test strips, they could have tested the product and perhaps avoided either death or ending up in the ER. And then you have a situation with the two women at OSU who you could say naively, I would not use that word, but who did not recognize the fact that now a lot of products, aside from illicit drugs, Adderall is a good example, are laced with fentanyl. And so had they had access to fentanyl test strips, they certainly could have had a different outcome. So and then you have the situation where I remember back when I was at Ohio State, and the problem was the pill mills down south, and there was a meeting at the faculty club. There were about 100 people, and we broke into small groups around tables and discussed it, and came back as a larger group. And I raised the question of, well, what would it take in, say, Portsmouth for a 10th grader or 11th grader to decide to stay home on a Wednesday and Thursday and write his or her English paper or study for their history test or something, instead of going out and doing drugs. And part of it, and I think why it's so complicated, is because oftentimes for for people that grow up in that kind of environment, there's not the willingness for good reason to invest in your future, because what kind of future are you going to have? So there were two economists back at Princeton that wrote a paper a number of years ago and coined the term deaths of despair. I don't know if you heard of that phrase, but it's really fitting for at least some of the overall population, not all of it, that they make choices that put them at risk for different reasons having to do with their life circumstances. So what we can do about it, I think that's where people, frankly, are pretty discouraged. I think the DEA, I guess the DEA could increase its budget and put more agents around and seize more drugs. That's not going to be any magic bullet. A lot of the fentanyl epidemic is supply driven. It's not demand driven. And it came about because producing this stuff became incredibly cheap relative to heroin. And with the internet now, you can be a small dealer in Columbus and get your supplies safely from somebody in Chicago or some other place. So it's going to be a very difficult problem. I think part of it is we have to improve public awareness. We have to have better local and state coordinated and integrated programs to develop the kind of policies that would best fit the circumstances of the population of Ohio or the population of Columbus or the population of Appalachia. And I don't understand why there's not, frankly, I'm a public health person, so that's my perspective, why there's not greater concern about the fact that this is the #1 cause of death from people 18 to 45. And what are we going to do about it? It is a man-made epidemic. It's not a contagious disease like COVID. But people are, I think, informed people who are working on this problem and who are doing research about it, are hopeful. I wouldn't say they're optimistic, but they're hopeful that, that things will change and we'll do a better job. But I don't know. It's a tough problem.
So it was a great talk. I'm not even sure I could ask this question because you've sort of answered it, but I feel like I'm missing something because the approach to this problem is harm reduction, right? With, Narcan distribution and fentanyl test strips and that sort of thing. And a lot of people do know about that, but maybe there's not enough people who have access. There's a law enforcement and supply chain. And I think that's it. Lots of people know, lots of people who are using drugs know that fentanyl is a problem. Lots of them know other people who have died. Some of them want that because they think that's the better stuff. And so it doesn't, I can't imagine what a policy would happen that could actually stop this other than hoping it's going to burn out on its own.
No, well, I think that's why people are discouraged. East Coast cities like Philadelphia, Boston, Providence, DC, are completely saturated with fentanyl, and the street users there, as I say, are fairly sophisticated about their drug use. And we don't have the data, as far as I know, to say, okay, of the X thousands of people who died in a given year, what was their profile in terms of how many, were street users, how many were like the two women at OSU. And so it seems to me that's a beginning step. We don't even have those kind of data. But I think, you get into the complicated question of why do people use drugs? They use drugs for different reasons, but there's no easy answer to that. And it just so happens that fentanyl is a very potent drug that kills easily and is killing a lot of people. And some of those people that die are nothing, they're certainly not part of the street user population. They're people like these two women at OSU, or they're kids who went to a concert on a Friday night and one of the kids scored something that they thought they'd get high on, and they end up in the ER or the morgue. I'm sorry. Oh, how can,
How can, what is going to make the curve go down?
I wish I knew. If I knew, I wouldn't be here right now. I think, I think we need something. This is a simplistic answer, but we need something along the lines of the smoking campaign in the 60s that didn't drop the death rate from lung cancer caused by smoking right away dramatically, but over time, and the expert is right here. I'm not the expert, but I think it's going to take much greater awareness, starting probably in middle school. I mean, I've had some people call me from different parts of the country because they were reviewing for different reasons school curricula and drug prevention curricula, and they don't. And now it's 2024, and they don't mention fentanyl. Well, to me, that's not the solution, but to have a drug prevention program being given in schools and not in 2024 and not mention fentanyl is a little hard to understand. Obviously the DEA has to continue to do their work in terms of reducing the supply. I think it's what some people think. Rand did a big study. It was published a number of years ago in 2019. And they made the point that it may be easier for the DEA to not go into a market like on the East Coast that's saturated with fentanyl and reduce that supply, but is to prevent new markets from emerging in the Midwest and the West that now don't have the fentanyl overdose that the East Coast cities have. But it's going to be a very hard problem to solve, I'm afraid. Yeah.
Yeah, thanks for all that information. Very interesting. About this synthetic fentanyl, what's the history of it? Was it accidentally discovered? And is there a natural analog for it? And how long has it been around as a synthetic chemical?
Yeah, well, it was first synthesized, I think, over in Belgium in 1960, and then started to have application as an analgesic for people who are undergoing surgery such as cardiac surgery and vascular surgery, and probably starting in 2010 or so, there started to be more importation of fentanyl directly from China. That's why I had that slide. It was called China White. And there were some evidences of, especially in California, but in other places, of ODs, a dozen people that took China White and didn't know what it was. And then for some reason that I'm not completely aware of, the supply really pivoted, as I said, to Mexico. So the precursor chemicals are sent from China to Mexico. They are synthesized in illegal labs run by the drug cartels there, and then they're shipped up here. So, and it's really not a problem of diversion. The problem is not one that fentanyl in large quantities is being diverted from medical uses to illicit uses. The problem is that it's being produced, it's so cheap to produce. And there's, the DEA people I worked with said, there's so much money to be made in fentanyl that, you could build a wall all along the southern border with Mexico, 100 feet high and 50 feet deep, and they just figure other ways to import, you know, to get the stuff up here. So it's a very serious problem with no easy solution in sight at all. Is your mic on?
Back on, sorry.
Okay.
One of the online questions, it was asking about what the appeal would be to people, for people to knowingly take it. Are there people that knowingly take fentanyl, and why would they?
What, so let me see if I understand the question. Is the question, why would somebody knowingly take fentanyl?
Correct.
Well, I think the answer is there are people who are fairly sophisticated in their drug use, their street drug use, they're longtime users. They have a dealer who they trust, and they like the high that fentanyl produces, even though it's a shorter high than is produced by, you know, say heroin. And so there are people who knowingly, we don't know the proportion. That's part of the problem. We really need epidemiologic data, which we don't have now. But there are people who knowingly, and they're fairly, as I say, sophisticated in their drug use fentanyl because it gives them a better high.
I wanted to ask if you haven't mentioned Suboxone as a treatment for fentanyl.
As a,
Treatment?
oh, yeah, I mean, I think there hasn't been, and I'm not sure why, there hasn't been a lot of attention paid to that, but I think in the future, that's going to be one of the more important treatment options, because I think there's, and I used to, when I was earlier in my career, I did quite a bit of work researching substance abuse outcomes. I'm sort of out of that now. But I think that there's general thinking that in the old days, we had residential treatment for, you know, people who were dependent, opioid dependent, and used heroin. But now I think there's come to be the feeling that buprenorphine and medical assisted treatment is probably the better way to go than just the drug-free old model of residential treatment. So I would imagine that that would be something that would become more commonly used.
In a cap or a tablet that's being distributed on the street?
That's a good question. I think, and well, I don't know. My best guess is, I'm a little out of my element, is that it's, I don't know, half a milligram.
In vascular surgery, we typically give 40 micrograms intravenously for conscious sedation with some Percet. And that's a pretty low dose, and it goes through pretty quickly, but it has a an effect. So a milligram would be an astounding amount, I would think.
We're trying to run around with the microphones here.
I mean, a lot of the, the street users who have been using it for a long time have built up a, fair tolerance. But
There's another online question I'm going to try and shorten a bit. Could there be a correlation between the increased accidental deaths and honest patients who cannot get temporary treatment for acute pain disorder injury from doctors, hence seeking access to illegally provided on the street fentanyl?
well, that's a good question. The short answer, if I understood the question, is, I'm not sure. The question is, if you're a patient and you need pain relief, either from a surgery you've had or you've got chronic back pain or whatnot, and you can't get appropriate medication, do people in that situation possibly turn to trying to get illicit fentanyl? That's I would guess, I don't think that would be common. I'm not saying that it doesn't happen, but I don't think that would be a common pathway. So,
Would they be more likely to go looking for oxy or something like that, a name they know?
yeah, they might, try and get it from a friend who had surgery and has leftover pills in the medicine cabinet. I think, and, the subject of pain relief is still, I mean, I'm not a physician, but I've done quite a bit of research and writing with physicians and who are pain management specialists out at the University of Washington. It's, things have really changed in terms of prescribing opioids over the last 10 or 15 years. I mean, there was a time when if you're an adolescent and you had your wisdom teeth out, that the dentist would give you an enormous supply of some opioid or liquid morphine or whatever. I think a lot of that is gone, but there are people who still, I think, have very legitimate needs for pain management and have a hard time getting prescription drugs. Our son, a few years ago when I was here, came to have some sinus surgery, and he had 3 or 4 spinal fractures earlier as a result of a car accident. So he knew pain, and he was in our basement with the lights out for 3 or 4 days, and they just gave him a 3-day supply of Vicodin. And I practically needed an audience with the Pope to get him, some Percocet for a few more days. So there certainly are people who have legitimate needs for, opioid to manage their pain. That's a much different situation, though, than if you're talking about surgery as opposed to using it for chronic pain management. That certainly is not the standard of care anymore, which is a good thing. Anybody else? Kind of coming up on 5:15.
I
Okay,
don't see any others. Thank you so very much.
all right, thank you.